So I'm really pleased to be moderating a discussion with two of my colleagues from such highly respected and prominent healthcare organizations, Kaiser Permanente and Molina Healthcare. But before I go ahead and introduce Dr. Phyllis Reims and Jennifer Rasmussen, I want to take a step back and explain why we're convening this discussion. We all know that changing a system of care can be very challenging, even when we know that it is in the best interest of the families we care for. Systems change requires tremendous amount of buy-in at many levels, setting priorities, mobilizing resources, adaptability, commitment, and oftentimes great innovation. As Kaiser South Bay and Molina Healthcare of California examine their needs of their membership, especially as they age, they identified dementia detection and support to families as priority areas. And in some cases, members with the disease, as we've heard, were not being identified, and their care was therefore not being adequately managed. And family caregivers were not systematically identified, assessed, or supported, and partnerships with local Alzheimer's organizations that could provide that education and support needed to be strengthened. So our discussion today is going to focus on how these two healthcare organizations partnered with Alzheimer's Greater Los Angeles, my organization, to strengthen their systems of care to make them what we would call more dementia capable. We're going to talk about how they adopted diagnostic and post-diagnostic care tools, practices, and strategies, how they systematized them, embedded them into their systems of care, built out workflow processes, trained staff, and then partnered with Alzheimer's Greater LA to support families affected by the disease. And last year in 2017, our partnerships were awarded honorable mentions from the SCAN Foundation's Innovation in Healthcare Award. Kaiser Permanente South Bay Geriatric Cognitive Assessment Clinic has a dementia-focused care model, which will be discussed today, and Molina Healthcare of California will discuss the Dementia CalMedi Connect project's impact on their system. So we hope that you all can implement some of these promising practices within your own organizations by learning from Kaiser and Molina's experiences. So we're going to roll up our sleeves right now and get really practical with how they actually did all of this. So now let me introduce my esteemed colleagues. So Dr. Phyllis Reims is the Chief of the Department of Geriatrics, Palliative Care, Continuing Care, and Social Medicine at Kaiser Permanente South Bay. Clearly you have a lot of enthusiasm because you oversee so many departments. And I met Dr. Reims several years ago at a conference. We sat, we ate lunch together, and we immediately realized that we needed to collaborate. And I'm always impressed by her leadership, enthusiasm, and commitment to improving patient care. And Jennifer Rasmussen is the Vice President of Healthcare Services at Molina Healthcare of California. And under Jennifer's leadership and keen appreciation of the needs of these vulnerable population, Molina's care management system has been strengthened to be more responsive to the needs of people with dementia and to their family members. And I've been fortunate to collaborate with Jennifer and her team over the past 4.5 years. So with that, I am going to be asking some questions. They are going to share, and then we're going to open it up so you can ask them some questions as well. So I'm going to give each of them about 5 minutes to share with us your promising practice and what drove you to implement those strategies. So Jennifer, do you want to start?
So I've had the good fortune to work in the area of geriatrics for a long time, have a lot of passion about working with folks in aging, and have experienced dementia in my own family, several generations worth. So this is very much a passion of mine and a commitment of mine. And I'm really blessed to work with a whole slew of colleagues from different backgrounds and credentials who share that same passion, interest, and experience. And as Molina Healthcare went through some really phenomenal expansion through the ACA, we were really lucky to be able to partner with Greater Los Angeles Alzheimer's to really make sure that our care management team that was growing so rapidly to take on all of this new membership that we could really make sure that our staff was prepared to assess and address issues relating to dementia. So we already had a health risk assessment tool that asked a 3-item recall and some questions about changes in memory and thinking. But with the training that we provided our care managers, who are nurses, social workers, community health workers, all levels, in order to really make what they learned in the training, really bake that into their practice and process every day, we needed to have those tools in our system for them to be able to access. And so we put a proposal together that had to go to our corporate team that manages the enterprise-wide software to say, here are some of the tools. Thank you. Here are some of the tools that we'd like to use so that we're not relying on our staff having to think, okay, they scored this, let me go find this other piece of paper somewhere here or some other Word document that we have to go through. It's just right there in the same system where they're documenting the answers to that health risk assessment. And it had to go through the governance board, all of those things that a large organization does to kind of control their different systems. And I really want to recognize my colleague Megan, who's here, because she's really the one that was on this and making sure every step of the way it was happening. So once we got that, we said, well, that's not enough. We need to make sure that this gets baked into the care plan, that our care managers are working with our members and their families. And with the support of Alzheimer's Greater LA, said, well, how can we better connect with the providers in the community, whether it's the specialists or the primary care physicians. And we worked with them on developing a letter template that if we had a member scoring in the 88, which is included in your packet, is the tool that we chose to put in our system. How do we notify those primary care physicians that this is what we've identified and encourage them to follow up and to use the tool, the one you saw this morning, as well as access other resources. And then the care manager, that's part of the care plan, is working with the primary care physician, encouraging the member and their family to follow up with the provider, to get additional screening or diagnostic, the referrals to the resources in the community. And while CalMediConnect was the line of business that really kind of got us going on this, we use those same tools with all of our lines of business. So our Medicare Advantage, which is a dual special needs plan, with our Medi-Cal members who are seniors and persons with disabilities. So this really covers our entire population.
Good afternoon, everyone. It's been my great pleasure to work with our geriatric assessment clinic. I actually was the first geriatrician for our clinic that was started about 16, 17 years ago. And we just were really trying to help change the culture at our medical center on really bringing geriatrics to the forefront. I was the first fellowship trained board certified geriatrician at our medical center. And we first had to kind of navigate who would go to neurology, who would come to our multidisciplinary geriatric assessment clinic. And it became very clear to us where the opportunity was for cognitive assessment. So we focus on cognitive assessment. And then we actually partnered with our Department of Neurology because we had the psychosocial support that they needed. So we felt it was very important that we then really target those members who are 65 and older. And then they will tend to manage those that are 64 and younger. But there are those that they really feel need the multidisciplinary team, so they will refer to us. So we really spent the first years of our clinic focused on detection, diagnosis. And we really have pretty much hardwired that. And as my colleague has said, you could imagine that almost overnight, we have blossomed, more than blossomed, in terms of the volume. But now, over the past years, we really have had to look at, we're doing a great job in terms of diagnosing and identifying. But what happens after that? What happens for those members who are no longer testable? Those that fail to return for follow-up? We do our best to manage those that we're seeing, but then as also my work began evolving into home-based care, I started seeing these caregivers, our members with dementia that are at home. And these caregivers are doing an amazing job. So it really helped us reframe that we have to start not only just looking at detection, diagnosis, identification, but that case management piece. So it was our great pleasure for me to meet Jennifer and for us to start talking about the vision and the potential for partnership between Alzheimer's of Greater LA and Kaiser Permanente South Bay Medical Center. And we've been partnering for about 4 years. Back in 2014, we began using let me step back. We started visioning using the ALS Direct Connect. And similarly, we had to go through quite a bit of discussion with our compliance, with our medical center administration about how we would do that. Sharing of potential medical information between our system and Alzheimer's of Greater LA. And Jennifer was involved with many of those discussions. And after several discussions, looking at medical release forms, having our compliance, look at the referral form, then we could come together and we've eventually, and it took time. It took about, I would say maybe about a year. It took for us these multiple discussions and back and forth for us really to be able to roll it out in 2014. And I really have to commend our nurse practitioner, Pamela Wong, and also my director here, Fran Izzo, with her great work Pam was telling me, we've had about 300 referrals over that time. And it's been really phenomenal. So usually, really very much when people come in for their consultation, we are referring them once we're diagnosing them with a serious cognitive impairment or dementia. And it's really added a very important layer, as has been said before. The psychosocial dynamics and impacts are just overwhelming. And again, as I stated, much of my work now is in home-based care, and I'm seeing it every day. And I think we're still really just getting at the surface. We're just scratching the surface of the potential to partner. I know Jennifer's told me, okay, Phyllis, slow it down in terms of what I would like to do with Alzheimer's of Greater LA, because we as a community of providers, we have to do even better job in terms of supporting the caregivers. And just think about who we're seeing coming into the emergency room. Sometimes these members or patients that have dementia or cognitive impairment, it's caregiver burden that's showing up. They're coming to the emergency room. And I think we all would agree that's not the best place for people to get treatment. And those that have cognitively impaired, they don't need that environmental shifting. It just wreaks havoc. And there's a lot of guilt that's tied in for the caregivers. And it's hard for people to ask for help. So it's really incumbent on us as providers of how can we, as more upstream, provide that support to normalize the need for support. So it's been a great partnership with Alzheimer's of Greater LA, with the ALS Direct Connect, and I'm really looking forward to increasing that partnership and looking again how we can work together, because for every patient, as we've stated, that we are referring or seeing, just think about those that are invisible, that are out there. And again, we only see them when they come to the emergency room, or they come to the emergency room, they get hospitalized, or they're going to our skilled nursing facility. There is no plan. And even more, there's people out there who don't have any support. So that's another layer that we have to really put all of our minds together to see how we can serve the better good.
So you both have brought up supporting caregivers and connecting them with a local Alzheimer's organization, but I actually want to take you a step back, which is how do you even identify the caregivers in the first place to even be able to make a referral? And then, Jennifer, I'd like you to speak a little bit to Melina adopted a validated caregiver assessment tool and put it into your system. So again, going back to how do we start with that identification to be able to assess and then be able to support?
You want to go first?
Sure. So as part of that same basic health risk assessment that the vast majority of our members are getting, assuming we can connect with them, so that there's a barrier there sometimes. And these are assessments that we're doing when members enroll and then annually thereafter. So we're asking them if they need help with any of their IADLs or ADLs. We're asking them if people are helping them, who that person is. We're trying to assess what level of help that they're getting. Sometimes we're speaking directly with the caregiver themselves and they're facilitating completion of that health risk assessment. And so we ask at that point too whether the caregiver is needing any help or whether the member thinks their caregiver needs more help as well. So we've always in our system had a place where we identified if a member had a caregiver, but through the training process, part of what was really emphasized is when somebody is having problems with their cognition, really identifying who that caregiver is or might be, because that's going to be the person that's going to help execute whatever care plan, care management plan that we're putting together. So, I think we've covered pretty thoroughly the support of the caregiver today and the reasons for that. The other tool that we added into our system was a caregiver assessment tool, and that really helps open up the door, and a copy of it is included in the packet. It really opens up the door for that conversation about what that person is experiencing in their caregiving. And just to pivot off a point that was made, it's important, I think, for us all to realize that there's a wide spectrum of caregivers. So, there's the caregiver that's there each and every day that, as Mr. Green said so eloquently, it's minute by minute. They're queuing, they're protecting, they're redirecting, it's the most basic skill. And then there's others where you may have an adult child that's in and out, and then there are remote caregivers, friends and family that are checking in by phone daily, weekly, and the needs of those different caregivers is very different as well, and their way of coping with the situation is quite variable. Somebody who's there day in and day out has a different experience, not necessarily more or less stressful than the person that's far away, doesn't know necessarily what's going on, may not be able to see and assess and help in quite the same way. And then for Melina, a lot of our population really doesn't have much of a social support system. So we have a lot of situations where there is no caregiver. Maybe there's a community, a faith community, or a neighbor, or maybe there's really no one. And then the care manager has to take a larger role in kind of identifying what other services can we help identify, long-term services and supports, other things like that, that will help to guide that person, and with all those, everything from the basic things to the more long-term planning. And so that's a real challenge. But again, getting that tool in, so that the care managers have a structured, focused, validated way to look at the spectrum of issues that that caregiver may be facing, and use that as the pivot point for then referring to resources, whether it's support groups or the telephone support line, et cetera. And One thing I really want to emphasize is we've got a vast network of care managers. They're in multiple offices in multiple counties. The resources in the different counties that we serve is incredibly different. What we have available to us in terms of specialists and community resources in Imperial County is night and day from what we have in LA. So, there's additional challenges there. But like with any set of professionals or paraprofessionals, especially in healthcare, which is constantly changing, new requirements, new evidence-based, the training and the retraining is essential because people have different comfort levels. Some people need the multiple repetition of training and how to use it and gaining comfort. And you you have to tend to it like it's a living thing, and you have to nurture that and refresh that training, remind them of the tools, not just using the tools, but what to do with the tools once the tools give them that piece of information.
I think you said it, really well. I think for Kaiser Permanente South Bay Medical Center, when you talk about how to identify who the caregiver is or the responsible party, is we try to do that also through our classes. One of my physicians, Dr. Tara Brown, has done an awesome job along with Fran rolling out a series of classes for new referrals to our cognitive assessment clinic for caregivers and patients if they are in a stage of their cognitive impairment for assessment that's appropriate. So we do a lot of education that way. And we're actually trying to really help change the culture at our medical center for the primary care providers, for the specialists to realize that you have to identify who is the backup decision maker. And that's a cultural change. It's a practice change because we have to move this identification upstream. One of of many challenging areas is after someone is so impaired, it's not just a matter of doing an advance directive. You're looking at conservatorship, and for many people, that's just cost prohibitive. Then you get into other dynamics, and usually or commonly it can evolve around money. When you have infighting among family, adult children and control. And as you mentioned, you may have one caregiver who is doing the hands-on care, but they're not the one who's calling the shots. And so there's just a lot of different layers. But we really are trying to encourage our cognitively impaired patients to identify the hierarchy upstream. And I try to introduce it in a way of taking that burden off of be it their adult children or their spouse or whoever that is. And as you mentioned, it's more of a challenge when there are no blood relative actively involved. And so they're creating their community and trying to determine not only who's over medical care, but who's going to be involved with their finances. And so it is very important. I think the primary care providers are very important. One of the blessings of being the physician leader along with Fran as my department administrator for social medicine is I work with the social workers. And so it really has been a great marriage by having our departments work together because we have social workers in each of our medical office buildings. And so we're still trying to help, again, change that culture so that the primary care physicians know when to reach out to the social workers. And with our social workers meeting together, there's a sharing of knowledge so that as situations come up in the primary care physician's office, that they can also help identify that maybe there's some cognitive impairment, or maybe we're in a situation where we need to help identify who should be the next in line for decision making. Do we have an advance directive? If it's appropriate, are we talking about the post form? So this is one of the areas that we're working on.
So Dr. Hayes-Reims, how do you get stressed out caregivers to go to an educational course? Because you've had a lot of success with your courses. We've offered our Savvy Caregiver program, an evidence-based caregiver education class, and then we rolled out Savvy Express because people can't necessarily go to 6 sessions. So we've done Savvy Express. We've tried to make it a quicker path to giving some caregiver education. How have you been so successful in this?
I think the most important thing is upstream, is you want to try to catch people before they're in crisis. If we can do that, if all of us can hardwire that, that's the challenge. And trying to figure out how to channel our resources. And we're no different than other organizations because you have to continually evolve. What may have worked before may not be where we need to focus so much now. Or also, how do we get out of our silos and not just say we have to carry everything ourselves? Where are there other resources? So again, that's why it's been so helpful and really a blessing having Alzheimer's of Greater LA to partner with, so that we're not trying to, in other words, you end up doing nothing because you're trying to do it all. But here you have a community-based partner who has it hardwired and can, come alongside with you and partner with you to get our members, our caregivers, the services they need.
There's an awful lot of turnover in the healthcare industry, we have learned. How does Molina sustain a training program for staff?
It's really tough. And sometimes you get a wave that makes you realize you're paddling upstream harder than you were. So we used to have our own trainers within healthcare services and even within our care management department. So we had separate trainers for our staff and separate trainers for our case management staff, and we really had a lot of control over what the content of that training was, so that we could, as new people came in, we could designate what that foundational training was, and we could, at the drop of a hat, do an assessment, see, here's a tool that we see our case manager, we could run a report, not that many people are using this assessment tool, let's do a refresher training, and we could really pivot. So our challenge right now is that through some reorganization, some of those training resources have been centralized. And so part of the advocacy that we're going through right now is how do we get those resources back local, and not just local to our organization, but be able to service, because we're spread out. We have staff in Imperial, San Diego, Inland Empire, Sacramento, LA. So that's a challenge, and one I'll admit we don't have a great solution to, but up until recently, that was really how we sustained it. And just to go back to the sort of the foundational training that we got, I mean, being able to partner with outside agencies is still very much what we do, whether we're talking about, getting our staff more education about in-home supportive services and how that process works, and how we can partner with, the county similarly with Alzheimer's. So Molina's model is we employ our own care managers. We don't vendor that out. So we have a lot of control over how we train them, when we train them, when we can take them off their regular job to attend training. So we had nearly 80 staff, care management staff, that we trained with the Alzheimer's in that base level 1 training on dementia care. And then we had about 22 or so that went through that level 2 training and now are the on-site subject matter experts within their local team, so that as folks are running into issues and maybe they weren't part of that training, or it's been a while since they have that training, they have their on-site subject matter experts that they go to. And I think you can't underestimate the power of having subject matter experts embedded in your team. And so I'm a strong advocate of don't have your dementia care experts siloed on their own team. Don't have your behavioral health people siloed or your skilled nursing experts siloed. Have them all together on the team. They're in the same interdisciplinary care team meetings. And there's a lot of informal training that goes on every day in the office because you know your colleague that sits 3 cubicles away has got that more intensive level training and is a resource. So, you know, we're at a little bit of an impasse on some of the formalized training, but that doesn't mean that other kinds of training aren't happening each and every day.
I want to ask if there were another organization or practice that wanted to take maybe just one of the strategies or tools that you've adopted, take it off the shelf, what would be their first step?
Well, I think for the ALS Direct Connect is you would want to get all your materials together and identify your compliance officer, identify, you know, who are the stakeholders. And I would get them engaged early on so that they're all hearing the same information. Additionally, I would reach out to Jennifer and the staff so that you can have someone from Alzheimer's or Greater LA to come so that there's a face. Because I think that overall, our organizations want to do the right thing and they want to protect the privacy of our patients. So that's usually the biggest concern. And I think that we did some of that, but I think if we had maybe done it from the beginning, it may have cut down on some of the time, just having the right people in the room. So once we did get the right people in the room, and they really had a good understanding of what we're doing and that it would be secure and we can trust Alzheimer's of Greater LA, then we were good to go. And we've, you know, but I think that's the key is to get the right stakeholders in the room, get them engaged from day one.
Have a plan kind of mocked out.
Right.
And then find key champions at the right level that are going to make the difference within your organization. Because those people not only will back you up when you have to push for that change, but also, you know, when you need to, they can say, come on, we need to do this, and here's why, and they've got that political capital.
I thought we'd spend the next 15 minutes allowing you all to ask questions. How did you do this, and how can we do this? But I'm going to keep questions and answers very brief because clearly we cannot tell you how to change your systems of care in 15 minutes. But I think if there are questions, I'd like to open them up to asking very quick questions and then hopefully giving some nuggets of information.
We've heard nothing about the scale. Both have been at it 4 years. We know approximately 1 in 9 have Alzheimer's or a closely related disorder of people over the age of 65. Take that 1 in 9 of your Medicare population at Molina or at Kaiser South Bay. Tell me how you're doing. Are you seeing 5%, 50%, or do you have a clue?
Well, as you said, to be honest, that's one of our next steps is data. We don't have the outcome data. We can tell you approximately how many have been referred, but and that's what I was mentioning, about 300 have been referred. But in terms of the outcomes, that's really our next step.
So 300 out of how many Medicare beneficiaries at your clinic?
I'm going to throw the ball. I know Fran is going to kill me. Of how many referrals that we've had over the past year in the geriatric clinic. About 1,000. We don't differentiate between Medicare and not Medicare. So these are all of our members, yeah. And so that's why I pause when you say Medicare. We're members, so that to us, it doesn't matter if they're Medicare or not. They all get referred.
And I didn't bring that sort of data with me either, although Jennifer and Megan and I were having a conversation a couple weeks ago about how can we get into the data, do some study, try to look at how many have been identified. You know, if we can see of the members that we sent their primary care physician the letter saying, you know, here's how they scored on the 88. Can we do a chart abstraction to see, did it make it in there? Was it already in there? Did it make it in there after we made the referral? And you know, that's difficult with our population. We've got, you know, everybody that we serve is poor and has Medi-Cal. So we've got a lot of social determinants of health that often are in the way of a lot of basic medical care. And so part of the reason why we have such a mixed team and social workers are embedded and provide a lot of our care management is because we're addressing basics, housing, food, transportation. You know, even if you make that referral, even if that physician's willing to do the diagnostic test, we got to get that member there. And if it's something that's going to require multiple follow-ups, those are challenges that we work.
And I'll throw out a challenge too, which is we may not have outcomes, but I would say, have we even run our ICD-10 codes? Have we even looked at pharma data for the people that have a diagnosis and it's documented? Have we even looked at that data as a starting point? And a lot of us are probably nodding our heads, no, we haven't run ICD-10 codes. So we need to at least start with something that we may even have. Okay, over in the back.
Well, I have a question to Phyllis. What's the denominator for
My
your
mentor,
1,000?
just so you all know, okay?
Question number one, the denominator for the 1,000 of you seen, in other words, out of what pool is that? What kind of population you're talking about? Two, both you and Jennifer are dealing with pre-capitated or capitated kind of population. So you have a system, you have resources, but I wonder why the Alzheimer's LA have not put anyone from the fee-for-service there, because that's the challenge that more than 2/3 of the population in California actually face, where you don't have a social worker in the office and all those nice things, and I commend you, this is beautiful. And it really doesn't matter if you're so 1,000 or 2,000. You've done the right thing, that's what counts. So it's a model application and implementation. Fee-for-service cannot do that. So maybe you can comment, how would you do it if you were in a fee-for-service?
I think that it's a great question, and I want you to answer as well, because I think about that sometimes when I talk to colleagues that are working in the fee-for-service arena. And I think it becomes, I'll just say my own opinion, it becomes even more important to have partnerships. You can't do it by yourself. You may or may not be able to employ a social worker or case managers. So then you really have to look at, are there, again, my opinion, are there practices of geriatric social workers? Is there a practice of geriatric psychiatrists or psychologists that you can pool your resources to? Because definitely it's all about team. It's definitely about team. So that would be my short answer.
I'm going to digress a little bit, and I'm going to make an observation, and you can see if you agree, disagree. So the first 10 years of my career was all at VAs in partnership with medical school, and all we did was social science research. And when I got my master's in public health, it was all about interventions and researching and what's your study design. When I got into the managed care world, I was blown away because that's not the way they think. On the payer world, they don't think that way. And so it's a, yes, certain, quality requirements and other things are pushing some culture change within our industry. But that is not a core basic. And even if we have people within our organization that are statisticians and, they can, run utilization data and tell you exactly how much you spend on ICU care, that's a different animal than talking about how do these kinds of quality improvement projects get implemented, and how do you figure out who's your control group or your baseline data, your pre and post. So we're not there yet, and we're trying to move that needle and partner with organizations who can give us some competency around that, but that's not my experience in managed care.
Patty Mouton from Orange County, another
You're
local
gonna not let
Alzheimer's.
me hold it. Well, I'm from Alzheimer's Orange County, and we have a similar program called Direct Referral that is embedded in the systems of a few of the health plans in Orange County. My question for you, and for really anybody here, why couldn't a health plan run data on everybody that's getting Aricept, Namenda, or Exelon and just automatically refer them to a CBO that could provide some help? What could possibly be wrong with that?
I will say that when I mentioned we don't have our outcomes and data, that's actually where we are right now. Because Fran and I, we've been talking, and she knows this, we've been talking, it's my passion area of mine, is how we are case managing our members that have been diagnosed. And we want to do, we have opportunity to do a better job. That's just the honest truth. And one of the things that hurts my heart the most is someone maybe we've touched and they've kind of been lost, and they show up in the emergency room. And so that's where we're trying to close the gap. So we're actually looking at, to be honest, we've been so much in the trenches, just trying to do the work and trying to deal with putting the right resource in the right place, that now we need to step back and be more strategic. And key to being more strategic is doing something similar to what actually was raised, Dr. Osterwald and yourself and the gentleman there, on now how do we capture the information we need so that we can be more strategic and tell the story.
Organizations like ours really want to have our phones ring off the hook.
Yes.
We would love it if we had to go to our boards and say, we need 15 more social workers.
But let me
And the pharmacist, yes, that's right, Becky.
but let me play this out for you a bit. So let's say we run that list and we find 2,500 members. We don't have resources to call all those people and walk them through that. We can't send them a letter and say, hey, you or your loved one has dementia and here's these great resources, because what if they're that 50% that their provider hasn't talked to them and they don't really realize? So we got to really think through this whole process. Okay, we can do that, but then what do we do with that, right? It's just like sort of the principle of you don't screen people if there's really nothing you can do about it. You don't identify and give people resources if their ball isn't in the wrong place on the putting green, if we're going back to our.
Right.
So I see where you're going. We absolutely could do that. Just run reports and find that out, but it's more nuanced than that.
Sure, but I would think that there should be a way to be able to at least have a bigger chunk. Our results with our Kaiser in Southern California, in Orange County, are similar, but our numbers are smaller because we only have 3.5 million people in the whole county. But we should be seeing probably another 75% more than we currently are, even though we're really happy that since July we've probably had 500 Kaiser patients referred. We'd like to have it be 2,500.
We're going to take probably one, maybe two more questions.
Hi, this is a question for Jennifer. It seems that your annual health assessments are not done by the primary care provider. Is that so?
So let me clarify. We're not talking about that annual wellness visit that's a Medicare. We're talking about the care management health risk assessment.
Right, but how do you, where does that happen? I mean,
It's primarily telephonic.
so you're having care managers just call to do that assessment rather than it being part of, because I'm struggling with, how are you connecting with the primary care provider who's taking care of the patient?
So sometimes we are and sometimes we aren't. So, we have a mandate through our contract with the state that every member that enrolls that's a seniors either in the category of SPD, senior persons with disability, or they're a CalMedi Connect or one of our dual special needs plan, we have to, within 90 days of enrollment, outreach to conduct this health risk assessment. And all the questions on that have been submitted to the state, approved by the state. And so it's a machine that we, as people enroll, we are outreaching to go through that interview with them and talk about what their medical diagnoses are. We do the PHQ-2, we do the cognitive screening questions, we ask them about their ADLs and IADLs, and then we do that again a year later. Now, we only reach and are successful with about 60% of the people that we outreach to. And based on the results of that health risk assessment, then we build an individualized care plan. A copy of that care plan is sent to the primary care physician along with other materials. So for example, if through this process we've done the 88, then we will send the letter and the results of that 88 to that primary care physician. And we often call to the office and we'll engage. A lot of times the new members don't even realize that they've got a primary care provider that's assigned to them. So we're encouraging that member, hey, you're new with Molina, here's your doctor. We want to get you set up with an initial visit. I'm going to be sending them, the results of our conversation today. So that's how that works.
And are you doing this system-wide? I'm in San Diego, and I've been working with your medical director there about including tools for the primary care providers, but she didn't mention anything about getting connected, the geriatric patients being connected through this health risk assessment.
Okay, well, we could follow up on that.
I think we will take
And yes, it is system-wide.
one question here.
Thank you. First of all, I just want to say that I do know Dr. Reims, and I want to say that she's not only an amazing, amazing clinician, but she also has the best bedside manners with patients, and she totally understands collaborative care, which myself as a pharmacist feel that's very important. And to follow through on that person that was talking about running data at Kaiser, because, my husband works for Kaiser. He runs a lot of data on medications, and I think it's a good starting point, but also I do feel that clinical pharmacists and geriatric clinical pharmacist specialists like myself are really great at screening for medication use or inappropriate medication use. So that would be a good start. But my real question is, what does your nurse practitioner, what is her role? Is it different than yours? And if it's different, how do you differ?
Well, and that's a great question because it's also been an evolution as well from when we first started our clinic. But our nurse practitioner works alongside our geriatricians. They don't do the initial consultation. They will do the follow-ups. They really are helping us in the case management role. She's also assisted us. Oh, thank you. I'm surprised I'm needing this. Okay. She's also assisted us with our educational classes at the time of referral, but does a lot of medication review. But to be clear, we do have a geriatric pharmacist who works with us in our clinic, so they help as well. But Pam has really been the one to help and really champion this work with Al's Direct Connect to make sure and facilitate that we're getting those referrals out to Alzheimer's Greater LA. But she's working as a care partner and a care manager as well in our clinic. Does that answer the question? We would love to hire someone. We'd love to hire a whole bunch of them, let me let you know. But that's a whole nother conversation.
I wish we had more time to pick your brains a little bit more, but we commend the work that you have started, and clearly there's a lot more for all of us to be doing, but it's helpful to hear how two healthcare organizations have started this process. If you'll join me in thanking our speakers.